This presentation is intended to provide a concise summary of the Sagittal Plane Shear Index, with particular reference to application for patients with lumbar spinal stenosis. The Sagittal Plane Shear Index is abbreviated SPSI and can be communicated in dialogue as SPSI. SPSI quantifies the translation of the posterior, inferior corner of the superior vertebra, in the sagittal plane, as occurs between flexion and extension. The motion is measured relative to the superior end plate of the inferior vertebra. Please note that this only quantifies the sagittal plane translation and is focused on the mid-sagittal plane. To account for variability in the effort each patient puts into flexing and extending, the intervertebral translation is divided by the intervertebral rotation. The intervertebral rotation is the change in the angle of the inferior end plate of the superior vertebra, relative to the superior end plate of the inferior vertebra. This graphic shows three-dimensional reconstructions from high-resolution CT exams of the 4th and 5th lumbar vertebrae. The right half of the spine has been removed to show the mid-sagittal plane of each vertebra. The flexed and extended positions of the spine are shown superimposed to illustrate the motion of L4 relative to L5. The L5 vertebra is stabilized so it remains in a constant position on the display between flexion and extension. On both the left and right sides, there is 13 degrees of rotation of L4 relative to L5, between flexion and extension. On the left side, the small magenta arrow shows the small amount of translation that occurs in a healthy spine. The right side shows an abnormal amount of translation. Intervertebral rotation is very important in our daily activities. In contrast, a human has no specific need for translation between vertebrae. In a healthy spine, the translation that occurs is the minimum required to allow for the rotation that is needed. Abnormally high translation can irritate the nerve roots and other tissues in the foramen, resulting in inflammation and symptoms. This shows 13 degrees of intervertebral rotation in both the left and right animations. There is a normal amount of translation on the left and abnormal translation on the right. A normal intervertebral disc is included in the left and a degenerated disc on the right. This helps to appreciate how the motion might affect the intervertebral disc tissue and any anatomy, such as the nerve roots in the neural foramen. The intervertebral motion is measured from radiographs taken with the patient flexed forward and with the patient extended backwards. Good patient effort is important. Since this is a typical activity of daily living, there is minimal risk in asking a patient to briefly hold a flexed or an extended position for the brief time required to obtain good quality radiographs. The importance of patient effort will be discussed later in the presentation. This is an example of good quality flexion and extension radiographs. Note the clear visualization of all disc spaces and the clear motion between vertebrae. As previously mentioned, the translation that occurs in a healthy spine is small. SPSI requires accurate and reproducible measurement methods. SPSI is calculated using intervertebral translation and rotation measurements that were obtained using quantitative motion analysis technology. QMA is the acronym. Independent research laboratories have validated QMA as described in multiple, published studies. The QMA method has been used to generate intervertebral motion data for many spine studies. So far, QMA data have appeared in over 120 peer-reviewed publications and hundreds of abstracts. These are a few of the validation studies. Please note that these studies are from some of the most prominent of biomechanical research laboratories. This animation conceptually illustrates the QMA measurement method. The first step is to import the flexion and extension radiographs into the QMA software. The X-rays are digitally compared through a superimposition process. Differences in the radiographic magnification between the flexion and extension X-rays are eliminated. Using pattern recognition, all available information about each vertebra is used to determine the position of anatomic landmarks defining each vertebra in both images. This is done for each vertebra. Matrix mathematics are then used to calculate relative motion between vertebrae. The accuracy of the method can be verified by checking that each vertebra can be held in a constant position on the display while flipping between the flexion and extension radiographs. This animation shows the process being repeated for multiple levels in the spine. In order to know what is abnormal motion, we must first carefully document normal intervertebral motion. This was done by collecting flexion and extension radiographs for several hundred asymptomatic volunteers who had never had any lasting back pain. These are data from one of the studies. Very importantly, QMA was used to obtain these measurements. It is critical to use the same measurement technology for both patients and the control population. There are significant differences in motion between levels, so it is necessary to define normal in a level-specific manner. For example, data for L2, L3 should not be used to define normal for L4, L5. Note that the translation measurements are expressed as a % of end plate width. That accounts for the variability in vertebral size between individuals. We can provide a clinician with raw measurements of intervertebral translation and rotation. They could then use those measurements to calculate the ratio of translation per degree of rotation, and then compare that number to a table of data for asymptomatic, healthy spines. That would be a burden for clinicians. We take advantage of knowing the mean and standard deviations for the healthy spines, and that the data are normally distributed. SPSI is provided to clinicians as a Z-score. That makes it much easier to interpret, since SPSI tells the clinician how many standard deviations away from normal are the measurements for a specific patient. A Z-score is a very well-established way to present medical data that is familiar to clinicians. If the translation per degree of rotation is exactly average for the healthy spines, then SPSI is 0. If SPSI is greater than -2 and less than +2, then the translation per degree of rotation is within the 95% confidence interval for the asymptomatic volunteers. If SPSI is greater than 2, we know that it would be rare to find this in an asymptomatic person with a healthy spine. In fact, it would occur in less than 2.3% of healthy spines. If SPSI is much greater than 2, this is very abnormal. Within a healthy spine of a single individual, SPSI is fairly consistent across levels. So, if most levels have SPSI that is approximately -1, indicating that the person's spine is generally on the stiffer side of normal, but one level has a SPSI that is +1.5, then it is reasonable to suspect that the high SPSI level is abnormal for that patient. Let us consider two example flexion extension studies. In this first case, you can see flexion and extension radiographs being alternately displayed. We are flipping back and forth between the flexion and extension X-rays. The first sacral vertebra is stabilized, meaning that it remains in a constant position on the display while the images flip back and forth. At the L5S1 level, the translation per degree of rotation is 3.3 standard deviations greater than the average found in asymptomatic controls. This is abnormal motion. At L4, L5, SPSI is almost exactly the average found in healthy spines, whereas SPSI is 6.5 standard deviations greater than normal at L3, L4. At L3, L4, most clinicians would likely not need SPSI metrics to appreciate instability, but at the other levels it may not be so obvious without SPSI. In example case 2, SPSI is generally between -2 and +2, so SPSI is within normal limits at all levels. Except L5S1 where the translation per degree of rotation is 4.4 standard deviations greater than found in healthy spines. This is very abnormal and would almost never be found in an asymptomatic individual with a healthy spine. SPSI has been measured at the treated and adjacent levels in multiple large spinal stenosis trials. All clinical trials were studies of surgical treatments for spinal stenosis. It is remarkable how consistent are the preoperative rates of abnormal SPSI in these studies. At the level identified by clinicians as in need of treatment, 25 to 30% of levels were found to have abnormal SPSI. Interestingly, approximately 40% of all patients had abnormal SPSI at some level in the spine. But the abnormality was at a level adjacent to the level identified for treatment by the clinician. Data for 2 lumbar disc arthroplasty IDE trials are also shown for reference. The inclusion and exclusion criteria for disc arthroplasty IDE studies are very different than for lumbar stenosis studies. Abnormal SPSI is far less common in the disc arthroplasty study patients compared to spinal stenosis patients. The facet joints provide substantial stability to a healthy spine, and there is normally no more than a thin gap between the articular processes that form the facet joints. As shown by the yellow arrows in this figure that shows a three-dimensional reconstruction created from a CT exam of a healthy spine. In some patients, an abnormally thick gap can be found between facet joints, and this is known as the facet fluid sign. An example is shown here. The green arrows point to the thick fluid-filled gap at the right and left facet joints. The facet fluid sign is currently considered to be one of the best available diagnostic indicators of instability in the lumbar spine. This is an example of one paper validating this conclusion. There are many peer-reviewed publications on the facet sign. SPSI has been shown to be significantly elevated in the presence of the facet fluid sign. This finding has been published in the peer-reviewed literature. This provides evidence that abnormally high SPSI is associated with instability. The possibility exists that SPSI could potentially replace an MRI exam that is ordered with the goal of detecting the fluid sign. SPSI can also be used to detect motion changes with time. For example, this shows the preoperative and 6-month follow-up flexion extension studies for a patient who had a decompression procedure at L2-L3. The third lumbar vertebra has been stabilized for these animations. The SPSI was -0.71 before the decompression, and this is within normal limits. 6 months after surgery, SPSI was 7.2 and this is very abnormal. Multiple research studies have been completed with the goal of documenting the development of instability following decompression. However, for lack of validated intervertebral motion metrics, these studies could only provide estimates. SPSI can be used to objectively document changes in intervertebral motion following decompression surgery, and can also be used to document changes in motion adjacent to spinal fusions. SPSI can also be used to document intervertebral motion following trauma when the potential for abnormal motion is of clinical concern. There is a key limitation to using SPSI in clinical studies. The limitation is that the patient must exert very good effort when asked to flex and extend for the flexion and extension radiographs. The flexion and extension positions must mechanically stress the spine, to the point where the disc and ligaments would keep motion within normal limits, if the disc and ligaments are functioning normally. The anterior drawer test for an ACL injury is a good comparison study. If during the ACL drawer test, only minimal force is applied to the lower leg, the test would fail to detect an injury if it exists. It is easy to understand in that test, that enough force must be applied to the lower leg, so that if the ACL is intact, a clinician could detect the restraint provided by the intact ACL. It is very clear that the ACL drawer test must be a stress test. Similarly, it is necessary to stress the spine enough so that, if the intervertebral motion restraints are competent, the restraint can be detected from flexion-extension radiographs. This is a photograph of the mid-sagittal plane of a human lumbar intervertebral disc. Note the disc layers spanning across the disc space from one vertebral end plate to the other. It is easy to appreciate that in the neutral position, the disc fibers are not in tension and are not providing much restraint to flexion rotation. However, after the spine begins to flex, these fibers start to restrict motion. And when they are tensioned, their ability to restrain motion can be detected. The spine must be sufficiently stressed during a flexion-extension test to determine if the motion restraints are competent or incompetent. Multiple biomechanical studies have documented the neutral zone in the spine. This is where it takes little force to get a fair amount of motion. Research shows that it takes 3 to 5 degrees of intervertebral rotation to get out of the neutral zone in a healthy spine. In a clinical exam, there must be 5 degrees of rotation to be confident that the disc and ligaments would be restricting motion if they are healthy. This is why 5 degrees of intervertebral rotation is required before reporting the Sagittal Plane Shear Index. This is a flexion-extension exam with too little motion. When there is little patient effort, like in this exam, the intervertebral motion is in the neutral zone and the disc annulus and ligaments are doing little to restrict motion. The vertebrae rock back and forth without stressing the intervertebral motion restraints. This results in a useless flexion and extension exam. In contrast, this is a flexion-extension study with good motion. This flexion-extension exam can be used to assess the intervertebral motion restraints. With sufficient patient effort, a simple flexion-extension exam can be used to diagnose when intervertebral motion restraints fail to maintain motion within normal limits. This slide shows data from a study where symptomatic patients were first asked to bend forward and extend backwards without any encouragement to try hard. Then the study was repeated, but the patients were encouraged to flex and extend as much as they could. It is clear from these data that providing clear instructions to patients can substantially improve the motion that occurs between flexion and extension. This will improve the ability to detect abnormalities. The good news from this study is that even symptomatic patients can generally be encouraged to flex and extend sufficiently to achieve a reliable diagnostic test. In the multiple lumbar stenosis clinical trials where we have measured SPSI, the patient inclusion and exclusion criteria were all very similar. Therefore, patients from all of the clinical sites should be very similar preoperatively. There is no reason to expect large differences in spinal motion between patients. This graph shows the preoperative, intervertebral rotation at the level that was subsequently treated. This graph shows the averages for each clinical site. This graph only includes sites that provided at least 10 patients. The data were grouped by the clinical site where the patient was imaged. The sites are numbered by the magnitude of average rotation. The error bars show the coefficient of variation. Note that some sites found almost 5 times as much intervertebral rotation, on average, as did other sites. This variability can't be from differences in patients, and is due to the instructions given to patients when the patient was asked to flex and extend for the X-rays. This graph also clearly shows that good spinal motion can be consistently achieved if the patients are encouraged to flex and extend as much as they can. The amount of flexion and extension is within the range of activities of daily living that might be expected for patients, and is not asking them to assume highly abnormal positions. The key is to use a flexion and extension protocol that consistently achieves good spinal motion. The data in this graph show that many sites can achieve this. Ideally, there should be at least 5 degrees of rotation at each level to assure that the flexion-extension test will either verify normal motion or detect abnormal motion. A simple lumbar flexion-extension protocol can be used to achieve good radiographs. This shows how a readily available walker can be used to provide support for a person while positioned for flexion and extension radiographs. A video is available on YouTube that patients can watch before going for the exam to help assure that they know what to do. This protocol was used in one of the studies where we collected lumbar flexion extension studies on several hundred asymptomatic volunteers. All volunteers watched the video before they went for the exam. Over 95% of the flexion extension studies had at least 5 degrees of rotation at every level from L1-L2 to L5-S1. Clinical sites would achieve multiple advantages if they adopt good spine flexion extension protocols. These advantages include a higher probability of detecting spondylolisthesis, if it can occur, and a higher probability of detecting abnormal motion, if it can occur. Use of a protocol where there is minimal motion between flexion and extension may fail to diagnose abnormalities, and is therefore unjustified use of radiation. In general, more accurate diagnosis will result in better outcomes, and this would be a reasonable expectation in lumbar stenosis patients. Good quality flexion extension studies can be consistently achieved, if the physician assures the patient that it is safe to flex and extend as instructed for the exam. And if the physician explains that the test may fail to diagnose what is wrong, if the patient does not flex and extend as much as they can. In addition, X-ray techs need to be instructed in the critical importance of good exams, and the patients should be educated prior to going for the exam. The other important limitation with SPSI is that when a clinician gets a SPSI report, they must verify that the vertebral labeling is the same as they have been using. The SPSI report includes an image of the patient's spine with the vertebral labeling that was used to generate the report. This is necessary due to the possibility of transitional vertebrae, sacralized lumbar vertebrae and lumbarized sacral vertebrae. Thank you very much for your attention, and we hope that you found this presentation on the Sagittal Plane Shear Index helpful.